And thank you for having me here. And I am asked to talk about whether biosimilars are there to rescue in the management of chorioretinal diseases. I have disclosures in the last 12 months. I do have disclosure with various biosimilar companies overseas and here. I do not have disclosure, though, for any companies in this particular presentation. So we've been trying to understand biosimilars from various point of view, whether it's phase 3 trial design, whether it's real-world data, or whether what happens in terms of the switching. So, and what is the kind of immunogenicity that you can expect. So this is our contribution in the forms of various publications in last 4 to 5 years. And I would definitely like to acknowledge this wise group of collaborators across the globe who have been part of all these studies. So before I proceed further, I have a question for this particular wise audience, that how many of you are aware of biosimilar anti-VEGF? If I can have a raise of hands, please. Great. So I see approximately 60 to 80%. And next question is, how many of you are using that in your practice? So again, this comes to approximately 60 to 70%. So awareness is there approximately in 80% of the audience which is here, and users are approximately 60% that I see. So rescue means, what do we understand by rescue and why are we even talking about this? So if you really look at the entire structure and the availability of molecule that previous speakers have talked about, and Dr. Shashank, I liked your one slide that you said, I start with the ranibizumab. That's where we are. So the gap which was there for the rescue was between Avastin and Lucentis. So this was a big gap which was not being filled up. So we were starting with Avastin, and Shashank said, now I start with ranibizumab. Why? Because biosimilars are financially able to fill that gap now. Now, why that gap? There is a need behind it. If you really look at the entire population of India, we are not a great country in terms of statistics, but overall, whatever data we have, you require approximately 1 crore of patients anti-VEGF injections every month. Do we have that kind of affordability? We do not have. Whatever data that we have a lot of non-affordability. That's why there is a big dropout. This is not a question of our country alone. Means I work with Cimerelli and Biogen also. So what we have seen when I was in academy a couple of years before, when we were talking about biosimilars, in US people were not ready. That they said this would not work in the States because Avastin is something which we believe in, and Avastin is being fractionated in this country very well. So biosimilars might not have a great future in the United States. I was in Retinal last year. I spoke to the same team. Now, you know what is that stats in United States now? Biosimilar ranibizumab has taken over the Lucentis usage in the United States in terms of the percentage. So that's what it does. We have non-affordability on ground with patients, but you see the more robust systems, developed system, non-affordability comes in the system. So insurance is something, which will decide. And whether they have filled this gap or not, I will tell you by the survey. I lead an international group of biosimilar study, which is called InterBios Group, which we are trying to understand various parameters. So we had a survey that whether the rescue has happened in India or not. So what we asked, that what proportion of your patient, I think this answer we have just received by this poll in this audience itself. So you see biosimilar users are approximately 75% of the proportion of various practices is with biosimilars. And where Lucentis stands, it has shrunk down to less than 25%. Prime reason for usage of biosimilars, it reduces cost to the patients. That's what the rescue we were talking about. Do you think they have made a greater impact in terms of affordability? Yes. Do you want to use it in future? Yes. Rescue, as I said, this is something which has definitely come for rescue, and it has indeed filled the gap. This is a recent paper that we published. Means I wanted to highlight this because when I talk about biosimilars on any platform, after the talk, a lot of people come that, whether this molecule is better, this molecule is better. Somewhere the clarity is lacking because they are, people are listening about different molecules. So let me clarify here. Just look at this table of our 1 minute.
Please ignore that signal.
Yes.
You can continue as long as you can.
Yeah. Thank you for that.
No, we have time.
No, but still, I will maintain time. I do that. So, but I will take 3 seconds, which you interrupted me. Sorry for that. So, just to really summarize that, who is the originator molecule and who is manufacturing it and who is marketing it. So, we have the oldest molecule, Resumab, which is manufactured by Intas. It is being marketed by only Intas. So Intas has only one molecule. Then comes Ranizorel, which came after Resumab. It is manufactured by Reliance. It is being marketed by Cipla under the name of Vizumab. Renize, manufactured by Lupin, marketed by Sun as Osiva. And then Optimab, recently launched molecule, not come because of the initial trouble. So this is the rescue. I would quickly do that because 5-Avastin, I practice in Tamil Nadu, so sometimes government schemes, suddenly they do not approve. When they don't approve, then the next, your option is biosimilars. So these are some of the case examples there. Biosimilars could really rescue all these patients who were not financially well. So I firmly believe that many lives can become better, and they have become better. And if you believe in biosimilars, and if you have a cautious eye on them. Thank you so very much for your kind attention.
Thank you. Thank you so much, Ashish. We always look forward to your talks. I just want to now, we are talking about India. I mean, we still believe that in US, 50% of the diabetics don't get access to these biosimilars.
It is, so US, we are
talking... Jocelyn Group study.
Yes, so what happened is now, in last 2 years of data, if you see, US has 2 biosimilar ranibizumab molecules approved at this point. So Biogen molecule was approved only for neovascular AMD because DME dosing, which is approved in US, they did not test it. Okay. And that was the molecule which came first. Then next molecule came from Coherus, which is Cimerli, which is everywhere. If you look at Cimerli is available in United States, Europe, and UK with different names. So what happens, Cimerli, for the first time in the history of medicine and history of FDA, has received interchangeability approval without any additional testing. So suddenly, Cimerli got that approval, and now you see, within last 2 years, the amount of users have really gone up. I am doing a real-world data collection. I have 3,000 eyes to analyze for Cimerli now, and these are all across the globe. So, as you rightly said, the access part, that's what biosimilars they do. As of now, even in US, access is a trouble. But US comes to a bottom of the pyramid. Access problem is predominantly more in Europe, and Europe is the most mature nation as far as biosimilars are concerned. So this is the primary reason that biosimilars, they come in, they increase the access, whatever they have done. So you are right, because even US access was an issue.
Sure, that's great. And you mentioned about different companies marketing these Indian biosimilars. How do that make a difference between, adaptability? Like we ask the patient, should you go for this brand or this brand? Does it make a difference? Like Reliance creating or,
I mean, ideally speaking, this is the same molecule. This is the same molecule, so it doesn't make any difference. The only thing is, my worry, means which I always express on these podiums, is India is in a super hurry.
Huge.
We are in a super hurry. We are trying to bring molecules within 3 months, 6 months, which is not right. If you look at the Cimerli and Biogen data, means I agree that biosimilars go through a curtailed clinical trial design because you need to show that equivalence. The design is equivalence. So equivalence design, your primary endpoints are 4 weeks, 8 weeks, and 12 weeks. Because that is a slope where you can check the equivalence. After that, you can't check the equivalence. So those are short. But if you look at international trials, your safety is assessed till 12 months, which we are curtailing here till 3 months. And then we are going in the market because we are not that worried by legality yet.
Avastin is still the cheapest in RP center aims, majority, more than 50% we are still having Avastin because it's cheap. And now next is the biosimilars. So what do you think if the Avastin is available with
Sir, Avastin is still, that hang of safety still is there with Avastin. So I would say, with the competition coming in, you have really good pricing of biosimilars. So I think AIMS, AIMS has shifted after really, really long time.
Long time.
On resume, and I know my colleague Vinod and everybody is using now, even in ROP cases as well.
We have recently started in ROP cases.
Ashish, I have a few questions.
Yes,
One
sir, please.
What is the percentage of refractory cases when you are using a biosimilar in a AMD patient with CNVM?
Sir, I do not have any statistics but I think this is similar that we used to have with Lucentis.
I think you need to come up with, I'm hearing you for a very long time, you need to come up with the hard data. What are the range? Because see, there are a lot of people, a lot of hands are raised for using biosimilar. It is cheaper, okay, it's monthly injection you are giving, it's also okay, but if it is not working properly, you are creating more visual handicapness than the highly
So I have a
responsive
counter
agents.
question on that. So I have a counter question on that. That's where I talk about that there is a nocebo perception we published. Negative perception should go away slowly.
That's why we require hard data for that. While doing this refractory status of the clinical cases, we need to have the percentage, not only for biosimilars, it is also for the branded molecules which are available with different molecules. We are having all those data with already worked out. So if you don't know that, then what I will tell the patient in cases where it is refractory to a biosimilar, I will shift this patient, irrespective of the cost, because here the question will come, how will I save the vision? It is not the pocket.
So I agree with you. So my question is, phase 3 has really, shown the equivalence. And so you should believe the data, what Lucentis has already given. We already have the data that in what cases ranibizumab work. So you should see with the same lens. There should not be a differentiation of the lens between Lucentis and biosimilar. That's what.
Not at all. Not at all. But you go by the agent, the particular brand part is thing. And second is, will you use one injection is A brand, and the second injection that is required, second brand, B brand, will you use the biosimilars?
Yes, sir, we have done that study. So interchangeability we have tested, published as well.
And that is...
that does not matter. That doesn't matter. That doesn't matter.
That's good.
Yeah.
This refractory
All
status-
biosimilar are FDA approved or the any
So DCGI approved in India.
DCGI